Tamamdır. Sırada bir de mama vereceğiz mi? Starting. Tadi udah gitu di mana yang tadi kita dibalik pak kawan dengan ini. Mau deh. Korean lagi. Ada. Apa ada yang udah dari kamu? Halo. Ini apa? Ini kan? Udah berapa ini? Baru main. Ada sih. Di pantai betul. Oke. Ini Tapi aku tahu. Ya, aku tahu itu benar. Oke, berarti di bahasa ini. Kita sebenarnya itu kurang nomor di bawah itu berarti.
You berbuat pasien baru
And
ya lah
semangat sih.
apa pimpinan sama itu ini también.
Politics. Apa ya?
Apa aja? Iya, dia sih kita lihat ini kita tahu.
Ah, mantap. Dewa 10 kali gimana sih? Kilometer dari siang kan pendek.
Iya, benar.
Parvenire. Montare brilliant prima da settimana, quindi tutto eravamo dei da se la mia dove non si mette lì. Avevo 20 libri, e io il mio per la base, e grandi negri. Perché lui è sì, dai, dai. Rispondo.
Okay. Okay. Fine. So we have come to the last of my lecture series. Today is the last one. And basically, this is a topic that today we are doing is something that is a larger topic, but I'm only choosing 4 diseases which I would like you all to know. So what I'm going to do is I'm going to go through those 4 things, and then I'm going to have a small quiz. Yeah, just a very basic thing. And then I'm going to go into detail with the other stuff. The note is there, so you all are basically familiar with this. Okay, what do you see? 2 eyes, obviously. What do you see here and there? What's the difference? One is brown. Yeah. Other one? Have you all seen any blue eyes? Yes or no? Why is it brown and why is it blue? And where is this? We're talking about the eyes. Yes. What is the cause of this? It's changing color. Everybody has using different types of colors. Brown, you see black, you see green, you see blue, white. Each one has a different color. What is it? What is it that makes this brown and what is it that makes this blue? There is one pigment. The pigment is melanin. අපි ඔක්කොම අපි කළු වෙලා තියෙන melanin. The less you have melanin, the lighter you become. So the පාරේ melanin අඩු melanin. Right? So that is a lot of melanin in the eyes. Even if you become lots of melanin, it becomes darker, black. The less and less and less, here there is hardly less melanin. So therefore, what is the basically what does melanin do? It basically absorbs sunlight like a screen. It has many other factors, but that is this thing. So here more melanin, it's brown. We Caucasians have brown and black. But when it, sorry, we Asians, but the Caucasians are much more. Now, what is this? What has happened here? Have you seen it? This is no melanin. If you don't have melanin, what do you call it? That's an albine. Albine. See, the iris has no melanin. Iris has no melanin. So it's basically transparent. And you see the fundus, you just, this is the red reflex that you can see the fundus. So when you don't have melanin, you are not protected against the sunlight. So they are finding it difficult to go in the sun and all kinds of things. And then, so that is an albinoid. Haven't you all seen albinoid? White. So these are very common things that come across, and they all have also. So all this is the melanin and having and not is also transmitted by the genes. So that brings us to our topic today: congenital and hereditary disorders of the congenital things and hereditary conditions. So before going into that, we should know what is congenital and what is hereditary. What is congenital and what is hereditary? This is the two differences. Very basically, you have to know. Congenital means it's genetic, genital, congenetic, and it can have environmental causes. All in the genes. We are all, you all know about it. We have a set of chromosomes, and in that we get genes. In each cell, we have these things. So if it's genetic and it can be present at or before birth, it's a congenital defect. And one example is what we are talking about is the fetal alcohol syndrome. And then there are congenital microphthalmia, anophthalmia, congenital glaucoma, congenital cataracts. So it's basically due to genetics and environment. So you have a gene, and if the environment also acts on it, then you call it congenital. It can be present at or before birth. Now, in this rabbit, you see, it has the genetic this thing that when it's warm, it becomes white. But the exposed area, the areas, the temperature is less. So that becomes blacker. So they have the gene. But depending on the environmental this thing, if the body is warm now, so body is warm, therefore that area is white. These areas are less warm now, so that becomes black. So it has a genetic component and an environmental thing. So genetic things, so that is congenital. Right? So just remember that part on genetic congenital. Then hereditary means you are coming from your parents. Gene mutation transmitted from the parents to the offspring. It's the gene that is coming from the, and then in the gene sequence, this is a chromosome, and then you get genes, and there is a mutation, there is a change in that sequence. So that is the gene mutation, parents to offspring, parents to offspring. Just remember hereditary. The cause is genetic mutation, and the example we will be talking about is this Marfan syndrome and retinitis pigmentosa. So this just know the basic difference. I don't want to go into detail. Congenital means environmental and genetic. It's present at birth or before birth. Whereas hereditary is what you get from your parents. And that's due to a genetic mutation as a change in the gene. So basically that's it. I don't want to mention a lot of things in the note. You all got the note? Huh? Yes. Right. First disease that I'm going to talk about is uh, that's number one. Yeah. So what is RP? RP is a genetic condition. It's called retinitis pigmentosa. So the pigmentation in the retina, there is a defect. And if you look at the fundus, there is a degeneration in the peripheral part of the fundus, and you get these degenerative patches called bone spicules. What you get in the back periphery of the fundus, you have to know the retina, this thing. What do you get in the retina periphery and the center periphery? You get what photoreceptors do you get in the periphery? Periphery, you get mostly the rods. In the center, the macula, where you see the most, is somewhere here. You get the cones. Color vision, cones. Black and white is rods in the retina. So if there is a degeneration of the rods, and you get this type of bone spicules. Once you see this, with the ophthalmoscope, you can see you can't miss this one. This is a spot diagnosis. It's retinitis pigmentosa. It's a hereditary disorder of the eyes with loss of peripheral vision. It leads to night blindness, or you can't see the night because now it's affecting the periphery. So whatever pain, just like in glaucoma, this whatever pain in hand, and it's a hereditary condition, and it's due to the progressive loss of rods in the photoreceptor. The retina, you get photoreceptors, two types of photoreceptors, cones and the rods. The cones are in the periphery. It is mainly gives rise to the black and white and the cones. Whereas in the center, you get the cones. The cones are mainly due to sharp vision and color vision. So we are talking about the rods. There is a progressive loss of rod photoreceptor cells in the periphery. Therefore, they cannot see this. And the most common thing, night blindness. There, the haim passe, this is the thing they come first. After 6 or 7, when the lights are low, they can't see. So, in a regular person, you see this like a thing. But as the light goes down, you get night blind. And they cannot go. This is what they say. So then you dilate the pupil and have a look, and you see this type of thing. This is the characteristic. Retinitis pigmentosa, bone split. So retinitis pigmentosa basically is something to do with the rod, right? And you get night blindness. Got it? And the problem is that it's gradually progress. And they come, I have seen too many patients, I have seen many patients. What they see is, this is how it looks like. In retinitis pigmentosa, this is how it looks like. Maybe the optic nerve becomes a little whitish and pale, and that's the macula. Macula area is basically not involved until the later stages, but this is what you see. These are called bone spicules. Bone spicules on the retina. Retina, periphery, bone spicules. Bone. So, retinitis pigmentosa, rods, night blindness, bone spicules. What I want to have. So, and it gradually goes more and more. So, it's a progressive loss of rods in the photoreceptor cells. And gradually it becomes more and more and more. It becomes so bad. Sometimes it becomes so blackish in the periphery. And when it comes to the later stages, it starts to encroach on the center. And then this is basically later stages. It's coming into the center. The optic nerve becomes very pale, and then they become severely visual. So this is one condition that you have to give them low vision aids and aids to basically things. And I've got many patients, they have gone to university also, but gradually it's becoming more and more and more. So how do you investigate? You have to do the genetic testing because it comes down the line. And then you have to do electro retinopathy, and then visual field is the one that we do a visual field, and this is what you see. Center is okay until the end, but the periphery is gone. Retinitis pigmentosa, the visual field as tunnel vision. Got it? So retinitis pigmentosa, the main problem is in the rod. And there is degeneration. You lose the thing, so you get night blindness. And then the periphery, you get those bones. And when you do the visual field, you get tunnel vision. And they come because they can only see through that. You look at you, they cannot see. So if you want to see somewhere else, so they are basically looking through a tunnel all the time. And in the night, it becomes very worse. They cannot go out of the moment they go out, they are basically blind. So, and then they can get cystoid macular edema. They can develop cataract. On top of this, if you get a cataract, the central vision goes off. So how do you treat? Very difficult to treat. But the thing is, there is no single treatment for retinitis pigmentosa. The rods are basically nourished by vitamin E. So you give them as much of what contains vitamin A? The yellow stuff. So you give them as much as possible yellow stuff. Vitamin A contains all those. You can give them vitamin A tablets also. And then when it progresses, you have to give them low sugar. Just remember, then tell them, go ask them, be with them, and then go through the whole thing. And don't worry, we are going to basically look after you, but at the correct time, put them on low vision and then follow them out. So there are so many low vision things we have, John can now have to taught you about these binocular things, the magnifiers and things like that. So basically, from the beginning itself, they need a class of, and then you have to follow them up, and at the correct time, you send them follow. And the vision goes down and down and down. So that is retinitis pigmentosa. Right? RP, rods, night blindness, the periphery, there is bone specules, and you get tunnel vision, and they may need low vision. Sorry. Low vision. Low vision. Got it? And we give them vitamin A. Vitamin A. Because rhodopsin is the pigment inside the rhodopsin. For manufacturing rhodopsin, you need vitamin A. In පුළුවන් තරම් කහ පාට එළවලු මොකක්ද කටේ කියන්න ඕනේ every day they come and ask මේක වෙන කරන්න දෙයක් නැද්ද? Have you been eating these things? Yes. So that is retinitis pigmentosa, a hereditary condition which is caused by a degeneration of the rods. Good. That's one condition that I am going to. Come to the second one. Anybody knows what Down syndrome is? Ever seen a patient with Down syndrome? Down syndrome is it's a genetic disorder caused by an extra copy of chromosomal 21. We have 20 chromosomes. There is an extra chromosome in those people. So there is an extra chromosome in Downs. And it's about 1 in 700 live births. If your maternal age goes up, the chances of you getting a Down child is elderly, you become pregnant, the more chances of you getting a Down syndrome child. Seeing these children, you cannot miss them. Downs is classical. All of them have this face. Seen Downs? Yes? No? Never seen? They are very lovable. They are mentally little down, but they are very lovable. They go on to become adults also, but they have lots of eye problems as well as, other problems. The systemic features are they are intellectually low, and then their their movements are very hypotonic. They don't move around that much, and then they may have congenital heart. Heart is affected in most of them. And when it comes to the features of the eye, you can see there is a flat face. Profile is flat. There is upward, palpable fissure is a little upward. And then these are called epicanthic fold. This top thing comes this way. And that is the characteristic of epicanthic. No, all the Chinese people have that. Seen that? Chinese ones. Epicanthic folds, and there's a small nose and a short stature. They are very short and they are very lax joints. So these are the ways. The moment you see them, you can basically hear down space and you cannot miss them. They are very lovable. They like to talk with you. They like to do all kinds of things, play with you. And as they grow up, although it's like that. I bet so many down patients and they're doing okay as long as we have parental esteem. So, what happens in the eyes? They all have refractive errors. They need a pair of glasses. So, to most of the time hyperopia, I've got mild patients also, astigmatism. They can develop a squint. They are mostly having squints. Nystagmus is the dancing eyes. Yeah. And then, so the eye, inside the eye looks like that. There is a little bit of the hypoplasia of the macula and this thing. And then they have this, not all of them, in the iris, there are these white spots on the iris. They are called brush wheel spots. That is characteristic of this thing. And then I told you about the epicanthic fold. The fold comes like this. See, if that is the eye and that's the top part of the lid, it comes down like that on the medial side. And this is broad and flat. And that is called epicanthic fold. And they might have blepharitis. Keratoconus is common with them. And the most thing that I have seen is cataract. They all have cataract, some form of cataract. And in the beginning, it's very small, but as it goes, whether it's the cataract enlarges, and then we have to go ahead and do surgery. And then they may have lacrimal gland blockage because of this epicanthic fold. This is the punctum is basically occluded most of the time. So refractive errors is mostly common, and then I have seen lots of cataracts. So just remember the ocular features, and then brush wheel spots. You don't see it all the time. It's quite evident in blue irises. So these are the things that happen in Down syndrome babies. Refractive errors, they can also get keratoconus, and cataracts are very common in them. So how do you do? What do you do? You have in any of these people who are basically mentally tough, you have a lot of patience. And then you do a lot of not the normal way of doing a refraction. You have to basically get them. They are very cooperative once you are basically with them. So you have to do modified techniques, non-verbal. Sometimes they cannot express themselves. And then to get the cooperation of the patient. And you basically dilate the pupil, your side refraction, and you can do other refractors also. Now, this is a boy, and then the patient and positive reinforcement is very important. But then now, at the one, you give them something and then do it. And then this is a patient A boy with Down syndrome, he has hypoaccommodation. So when you have hypoaccommodation, this is the technique that you all do to do both distance and near accommodation. What is the range of accommodation? So you and do that and then do cyclorefraction and then and here he is wearing to prevent hypo accommodation, he is wearing bifocal. So he is wearing bifocals and this is how it should and it has to be followed. And then you have to basically liaise with all the occupational therapists, the other doctors, education. It's very important that they get some form. I've got a Down's patient. She's so good at cross stitch. You know cross stitch? Other thing or cross stitch? Cross stitch is a stitching way where they do nice painting like drawings. So you have to find the things and she had a exhibition also with cross stitch. Most of the time she brings her paintings to me. Now she's gone abroad. So the special education professions have to come in and you have to liaise with them. And then these are the blush field spots and these you can't see the early stages of posterior capsular cataracts. And they basically become more and more. And then once they go into the teenage stages and then the cataract becomes worse and by that time you do cataract surgery and they are fine. But their mental status remains basically the same. So it's very important to be very cooperative, follow them up. And then, so that is Down syndrome. That is Down. So we talk about Down. So what is the problem there? There's a chromosomal 21 chromosome, there's an extra, right? And how do they come? Basically, they come with that type of features where you have these facial characteristics, face and ocular. And the ocular ones I told you about, mainly they have these refractive errors and cataract. And I told you about the brush field spots. And then basically they need to be corrected properly and followed up. Follow up is very important. Follow up. Both ocular and their basically their occupation work. They are very good at singing. They are very good at dancing. And I don't know whether you heard about. There is a guy I can't remember his name. He has his own show, singing and dancing. Down syndrome. So you have to follow them up and then try to guide them down in their work. And most of the time, most of the people I've seen, the refractive error is either myopic, mostly myopic. And then you have hyperopia also. So that is Down. So we talked about retinitis pigmentosa and Down. So Downs is basically a chromosomal thing. So we covered two diseases. Got it? Yeah. Come to the last. The last two things that I am going to talk about is basically they are not very common, but they are ocular manifestations of congenital and infectious diseases. Two entities that I want to talk about. Two entities. One is called the fetal alcohol syndrome. Fetal alcohol syndrome. So what does that mean? Fetal means able, right? Alcohol means when the mother is alcoholic, the alcohol gets into the body. So if the mother is alcoholic, it goes into the child and it causes a lot of problems. So that's called fetal alcohol syndrome. And fetal alcohol syndrome, again, like Downs, they have a lot of features which can be, basically, there is a short nose and then undeveloped jaw. The other thing very distinct is indistinct filtrum. Above the lip, we get this thing called two things like that. That's called the lip. They don't have it. And the upper lip is very thin. Normally, the upper lip is very large, the upper lip is very thin. So it all depends on the amount of alcohol the mother consumes during the first trimester mostly. And the parental exposure to high levels of alcohol. What is the alcohol that you know? The alcohol we know is basically ethanol. Ethanol තමයි alcohol හදන්නේ. ඕනම alcohol. Ethanol is neurotoxic. Neurotoxic means it basically affects the nerves. So where is the nerve? The brain, all the other parts of it. So the ethanol basically crosses the placenta, gets into the womb, and in the thing it basically absorbs, or in the amniotic fluid it pulls up ethanol, and then they develop growth retardation. The child doesn't grow, and then their function, cognitive function, they cannot think. Cognitive function is gone, and there is developmental delay. And these characteristic features are there. The small head, eye openings are very small. Low nasal bridge, and the mid face is flat. And then this philtrum is missing. And the upper lip is thin. So when you see people like that, you have to observe people when they come. And then you can then, because of that, they have to live with this for a long time. And here is a famous actress, Mary Lance. She has fetal alcoholism. You can see the top, this thing is one, and there is no filter. This is flatter. She did become an actress. So just remember that fetal alcohol syndrome is maternal exposure to alcohol, especially ethanol. Ethanol. And ethanol is neurotoxic. And because of that, it affects the development, cognition, and so on. So fetal alcohol syndrome is mainly due to the mother consuming alcohol during the first trimester of pregnancy most of the time. And alcohol is also teratogenic. Teratogenic means your body parts, they need a certain amount of nutrition and things like that for it to develop. But alcohol prevents that. So they have certain ocular signs also. Microphthalmia, the eyes are very small most of the time. They can have optic nerve hypoplasia. Optic nerve doesn't develop. So they basically become blind. And they can get a squint, strabismus. The eyes may fall, there may be ptosis. Epicanthic folds are there. Again, in this reduced vision, nystagmus, and refractive errors. So all these things can occur, but mainly what you have to know about is this microphthalmia. And then the epicanthal, the refractive errors are there again. So fetal alcohol syndrome, basically the mother having lots of alcohol. And they can also have strabismus, and that is also what happens. Okay. So there we have talked about retinitis pigmentosa downs, and now we come to fetal alcohol syndrome. And then they have strabismus, microphthalmia, reduced vision, all due to the alcohol. Good. So we come done 3. Now we are going to the 4th one and the last one on this. Rubella. Rubella is a viral infection. And if the mother gets rubella during the first trimester, rubella is a fever and is a rubella virus, it can go into the fetus, and that's called congenital rubella syndrome. Congenital rubella syndrome. So, in the general features, they develop deafness also. Heart defects are there and develop frontal delay. This is how they look like when they are born. Rubella, have you heard of thing called German measles? German measles can make. They have a characteristic rash, and then it's like this. The rash is like that. Once you see that type of a rash, you always think of rubella. But now this is very rare because they are giving vaccination for it. So they can develop deafness. There is congenital heart, the heart defects will be there, and there is developmental delay. They don't develop properly. So they end up microcephaly. That means the brain doesn't develop properly. They can have heart defects. There are heart valve defects, and then they also get cataracts. Rubella gets cataract. Rubella babies cataract. But we don't get the rubella nowadays because of that's a congenital cataract. In both eyes, cataract. Born with cataract. Born with cataract. Small eyes, there may be, this is a characteristic thing. So this is called CSR. Congenital rubella syndrome. So that is due to rubella virus in the 3rd trimester. So, and then they have these features which I just talked to you about, microcephaly. The brain gets affected, heart gets affected, and the eyes get affected. And of the eyes, we see cataract, and then that is the most important thing that we are interested in. So they get cataract, and this is the thing that you see when you look at the fundus of a congenital rubella syndrome. It's called a pigmented retinopathy, just like in retinitis pigmentosa, you get what we call the salt and pepper fundus. Looks like salt and pepper, no? White and black parts all together. So that's a salt and pepper. Salt and pepper retinopathy. So you get cataracts and salt and pepper retinopathy. In congenital rubella, if the mother develops rubella, if the mother gets it, it gets fever. First 3 months, before they, if a mother develops fever, first thing that you think of is coming. But fortunately, we are now basically without, we have prevented this by giving this rubella vaccine. Normally, rubella vaccine is given in the first 3 months also, and now we are giving it to all the girls after 15 years and upwards. And this is in the immunization program that we have. And the girls are given this, so that prevents them from getting rubella. And because of that, we don't see rubella that much. That is the normal, our national immunization program. In the first year of life, we give the thing called MMR. Second year, we give this, and the preschool age again, and then school age is also we give this, and then the family in the females, in the childbearing age, we give rubella. This is MMR, and this is triple polio and measles. So rubella vaccine is given for females in the childbearing age from 15 to 44, and that has basically prevented us seeing congenital rubella syndrome. So there is a vaccine for this. To prevent. ඔන්න ඔය ටික තමයි මම අද කරන්න ගන්නේ. So this is what I want to tell you all. We talked about retinitis pigmentosa, dots, night blindness, peripheral bones, visual field is gone, and they need visual low vision aid. Then we talked about Downs. It's a chromosomal thing, and you get ocular changes, mainly cataract, and then you have to follow them up and then give the proper this thing. And then we talked about the maternal alcohol syndrome, mainly ethanol, which is neurotoxic. Because of the neurotoxicity, they have developmental delays. And then we talked about the congenital rubella syndrome, which is due to a virus called the rubella, which affects the brain, the heart, and the eyes. And what we get a salt and pepper retinopathy, which is like that. And for that, we have a vaccine called the rubella vaccine. Good. Now, before going to the second part of the thing, I want you all to do a small quiz. Let's see how your, oh, sorry. Oh, yeah. Quiz. Oh my gosh. I have not. Oh, can I stop this thing and give it my. ඒක ඔෆ් කරලා මේක දාන්න. Extra slide තියන්න. තියෙනවා. Yes, sorry. So, this is how we are going to do the test. It's called fist to fight. Fist to fight. Fist to fight. Fist to fight. Now, this is how it's. Fist to fight කියන්නේ fist එක කියන්නේ I don't understand it at all. Right? One can one finger. One finger now, I understand a bit, But I have some questions. Let's have it. 3 fingers now. I'm starting to get it, but I need a little more practice. That's number 3. Number 5, කියන්නේ මම ඔක්කොම මට තේරුණා. Completely understand and can explain it to someone. Got it? That is called is to 5. Right. Now. Please define what mean that. RP method down method fetal alcohol syndrome method CRS conjugal rubeola. Now fish to 5 can fish take an F. 1 finger is what? One. 3 fingers can 5 fingers can I5 F 1 3 5 F 1 3 5. I make it F 1 3 5. I can't F 1 3 5. Let's do this and see. Good. Now, I want somebody to come and if that is pigmentosa, put up your hands. What do you understand? Is it a fish? Number 1, 3, 5. Put up your hands. One කියන්නේ I don't understand at all. One finger කියන්නේ පුට්ටක් තේරෙනවා. මට questions ගොඩයි. 3 fingers කියන්නේ ටික ටික තේරෙනවා but our practice. 5 fingers කියන්නේ මට කියන්න බලන්න ඉන්නයි. Somebody come and put up the marks. Yeah, we can. Come your marks. Fist. 1 finger, 3 fingers or 5. Ignite the finger. 3 fingers, 1. 3 fingers, 3 fingers. Oh, 3. 3 fingers. Getting to get it. But we'll be sure to hang on. 3. Oh, I'm playing safe. Oh, they have to give it. Can't do that. So, that's the number 3 fingers. Good. This can 1. 1 can චුට්ටක් understanding. 3 fingers getting to understand. 5 fingers no, better there. That's retinoid pigmentosa. We have an answer. No. මොනවද තේරෙන්නේ? Put up your hands, whatever you feel like. Let go of it. 1, 2, 1, 3, 5. This 1, 3, 5. This 1, 3, 5. Down sitting. Oh, 1. That's good. 1. So that is 1. 1. I understand, but I have a question. I think. It's a 3, 3, 3, 5. There you are. And then 1, 1, 3, 3. 3 ekadeka guna 100. 3 ya bisa. Mahal. 5 make it 5. 1. 1 make it 3. Okay. We are coming to fetal alcohol syndrome. Fetal alcohol syndrome. Fetal alcohol syndrome. Alcohol dan part of the out of these, put up your hands. This, don't understand. 1, I understand a bit. 3, stop letting the phasing along. 5, fetal alcohol syndrome. 1, 3, what is this? 3, 1, I know, 1, 3, 1, 2, 3, I'm starting to get it, but I need more practice. Never keep thinking that. Detai, authorize. Good. Dekat. Dekat. Ini dekai. Dekai. Tunai. Authorize. Dekai. Authorize. Akan. Good. So that is good. Now we come to the last one. What is the last one? Congenital rubella syndrome. Congenital rubella එක ගැන මට කියන්න බලන්න. Congenital rubella කියන්නේ when the mother gets fever and the first trimester and then the people are called inspectors and then they have this. One, two, this 1, 3, 5. 3, 3. Tunai, aturai, 5. Ai, see, you see how things get into your mind. If you are familiar with lots of things, you tend to understand. If you have not seen it, then you are very certain. That type of thing is very important. So you can basically you yourself can that whatever you use. So just to recap on what we all did, just a quick recap on what we did. Just a quick recap. You did the retinal pigmentosa first of all, and then we went on to do this thing. The retinal pigmentosa, the main thing I wanted you all to know about is this bone speculation. And that's nuclear. And then I told you about the visual field loss, and then so the visual field is down constantly. Then we talked about vitamin A. It's a lot of rehabilitation, which was when we talk about the gowns, it's trisomy 21 chromosome. That characteristic face, you cannot miss that face. You have seen a face like that, you will never, they're so lovable. You like to basically talk with them, they will like to talk with you right of the whole of the day. And they always come and say all kinds of things which make you feel happy. Then down we talked about the brushfield spots, the epicanthic folds, and the ocular things, ocular hair, epicanthic. And then again in downs, they have refractive errors and they need to be followed up. In the fetal alcohol syndrome, we talked about the exposure to ethanol. Ethanol is the neurotoxin which causes damage to the there is developmental delay. Cognition is gone, and they have these characteristic features of that face. And then the squint is there, And then we talked about rubella. I told you about the alcohol. Yeah, rubella. They have this deafness, which I didn't mention very much, and heart disease. We've got that's mainly the microcephaly and the heart, and then talk about the cataract. And last but not least, this is the thing that I want you all to remember: salt and pepper unbound. There is a vaccine. Good. Now I'm just basically going to go through the other things which are very important, very common most of the time because it's related to your field, There are common genetic disorders which affect each part of the eye. One is the cornea. Most common thing that you all come across is the keratoconus. Now, keratoconus has a genetic predisposition. When it comes down the line, you ask their parents whether they have a thing. They can, and there is mostly there may be may not come from this thing, but there may be genetic mutations, and therefore they develop this type of thinning of the cornea. And then there is a thing called congenital hereditary corneal endothelial dystrophy, which is like this. The corneal endothelium becomes disarrayed, and therefore fluid gets into the cornea, and the cornea looks blue. Because of the opaque cornea is always blue. Have you seen opaque corneas? Mallange paint. Or dog, yes. Because the endothelium, this is the epithelium and this is the endothelium. Endothelium is not functioning. Therefore, fluid gets into the cornea. And therefore, it becomes opaque. So that's a congenital hereditary corneal endothelial dystrophy. We call it CHED. And that is autosomal recessive again. So two conditions in the cornea which has a hereditary keratoconus and CHED. Keratoconus and CHED. Then we come to another thing, the lens. You can be born with a cataract. They are called congenital cataracts. And then congenital cataracts are common, as I said, in Down syndrome. Inherited with autosomal dominance. And then ectopia lentis. The lens, you know, the lens is held with zonules. That is the iris on the side, and then you got the ciliary body like this, and the lens is like that, and these are the sonules. There are strands that basically come from the ciliary body to the lens. These break, and the lens basically moves out. And that is what you see over there. Oops, sorry. The lens, the zonules break and the lens has displays. That occurs in a syndrome called the Marfan syndrome, which is very common. And I have. And there is another condition called the homocystinuria. And that can give rise to, you can see the lens as basically to be there. As basically. Marfan is a syndrome where tall guys, hand is long also. And you look at the arch of their palate, it's high, and they have huge fingers. And when you look at the lens, it's like that. Lens has basically. I had a guy from Daphna. What do you think? And during the war time, we were brought in there, and then he had this type of thing. We could refract and get him somehow or other get some glasses because he didn't want to undergo surgery at that time. So we somehow or other gave him glasses and he was able to go to school during the war time. After the war, he came and we removed the lenses, and now he has lenses. So that is called ectopia lenses. The lens has displays. Congenital cataracts, ectopia lens. Two conditions hereditary coming down from the so we talked about the cornea, we talked about the lens. We are going to talk about lens. Right. So we talked about the cornea, the lens, and then the retina. I told you about retinitis pigmentosa has its bone spicules. Then there are two conditions which you may come across where the retina is basically not formed. They are severe visual loss. That's called Leber's congenital amaurosis. And then Stargardt disease is quite common. They are normal children. They, by the time they are 13, 14, they come all of a sudden with a loss of vision. And then to find out right at the macula, there is a degeneration. So juvenile macular degeneration is called Stargardt. And then I have a guy, it comes down the line, the mother also has it. That guy went to Morocco University and he's now doing a PhD. Both guys 624 vision. Their vision is also very much compromised, but he can basically fixate on this place and then he starts to Stargardt disease comes down with nothing can be done. Oh. And then this is very, very rare. You get Leber's hereditary optic neuropathy. They are born blind. The optic nerve is basically like a chalk. Chalk is optic nerve. It's dead, basically. Then there is dominant optic atrophy, optic nerve disorders that come down the line. And then the things that I told you about, albinism. I didn't put that down. Yeah, albino, I told you, albino. Albinism is due to melanin. I talked about melanin defect. So deficiency in melanin synthesis, there is nystagmus, photophobia, and then it looks like that. There's no melanin in the body, and then you get a very transparent iris. There's no melanin in that. Then aniridia, that means there is no iris. They are born without an iris. There are hardly any iris. Just imagine being without an iris. What will you complain? What does the iris do? It basically constricts and dilates, and it allows a certain amount of light to come into the eye. But if the iris is not there all the time, there is light coming in. So what do you get? You cannot face the light. Photophobia. Very difficult. And then there are contact lenses. It's a small pinhole contact lenses. Pinhole contact lenses. You see the pinhole in the lens box? Contact lens. So you put on that and then it's like that. I think I'm not quite sure. But I've seen them wearing that. That's very good. Otherwise, it's very difficult. They can't do anything. All the time light is coming in, they can't do anything. So that they are born without an eye. And that's called aniridia. Then I talked about Marfan syndrome where the lens dislocates, and then we talked about Down syndrome. Right. Let me show you something. See, that's Down syndrome. One, take a lamp. I country still. You don't know. Come on. Ayan, blame. Dynamic pattern. There is a video. That is ocular albinism. There is hardly any pigment on the iris. So you can see a trans-illuminated iris. The iris, you can see through that. And that is the red reflex over there. And they have a nystagmus. Keep on nystagmus because that's a sensory nystagmus. There you are. There. You can see through the iris. Light is coming through the iris. Hardly anything. Good. Last but not least, ටික මම ඉවර කරලා යන්න. මේක ඉවර කරන්න. So we just want to go to the last bit of it. Now, how would you diagnose any of these things? You have to take a good history, especially with the parents and the family. And then you do an examination, examination. The other thing is you do a refraction, that's very important. And then if there is a necessity, we do a B scan to find out this thing. And then genetic testing can be done. We can physically send blood samples for genetic testing. And then to find out whether the retina is working, we do electrophysiological studies, ERGs and EEG. So history taking and examination is very. These are, by the way. And then how do you detect? You prevent amblyopia. Mainly if they have high refractive errors, mostly sometimes it's more than one is more than the other. One eye becomes amblyopia. So you have to prevent that and then give them proper glasses, and then you have to counsel and sit with the patient and the parents and then talk with them. And if when the time comes, you have to send them for low vision. And if there is cataract extraction, squint surgery, accordingly you send them and then get it done. And then most importantly, follow up. It's a lifelong follow up. Once they are your patients, they come to you over and over again because they want your opinion once you do it. So as optometrist, you have to recognize the signs early. Here I told you about the patient with the hypoaccommodation. Therefore, they are given bifocal lenses. Refer to specialist care, monitor the visual development. Most of the time they improve. And then educate the parents, and then work is important. You have to basically go through a multidisciplinary thing. Occupational therapists, it's very important. School teachers, you talk with them and then follow them up, and they do very well. Like you follow them. Good. That's about it. That is our beautiful island. You can't see. That is through the satellite picture. Can you imagine that we are in the place like this? Good. Thank you very much. It's been a pleasure talking and teaching you all. Hopefully, you will be doing well. I will not be able to. Excellent.